Hi, I'm Jim Brett, the President and CEO of the New England Council. Thank you for tuning in this month's edition of Inside the Corner Office. Council launched Inside the Corner Office as a monthly virtual event series back in the fall of 2021. And we've been fortunate to welcome an incredible lineup of guests over the past year and a half. Now, in 2023, we're excited to relaunch the program as a monthly YouTube series and podcast. But regardless of the format, the goal remains the same: to give our members the opportunity to get to know some of our region's chief executives and to learn more about some of the incredible businesses and organizations that are driving growth and innovation in our region. This month, we're thrilled to welcome Chris Palmieri, the CEO of Commonwealth Care Alliance, headquarters in Boston. Commonwealth Care Alliance is an integrated healthcare system that serves individuals with significant needs. And as I learned from my conversation with Chris, the organization has a unique and innovative approach to serving their members. Thanks for tuning in. I hope you enjoy the conversation. Thanks for joining us today. And needless to say, we're thrilled to have you as our first guest in our new podcast and YouTube series format for Inside the Corner Office.
Yeah, thanks, Jim. It's great to be here with the New England Council. So I appreciate being a guest and certainly your first guest of 23.
Well, we'd like to start these conversations getting to know our guest a little better and learning more about how you go to where you are today. So you've been in your current role for, I think, over 7 years now, but you have a very long and a very successful career in the healthcare industry. Tell us a little more about your career path and how you got to where you are today.
Yeah, I appreciate that. And I have been blessed to have almost a 30-year career now in healthcare. It's ironic. I come from a family of I have 3 other siblings, all of which in some way were in healthcare. I have my oldest brother he's a healthcare CEO in New Hampshire and running a long-term care retirement community. My middle brother worked in dietary services and healthcare for over 25 years. My sister was trained as a nursing home administrator and now runs a large veterinary medicine practice in upstate New York. My mom was a nurse. My late uncle owned adult care facilities. And when I sought out to be educated as a young man, I was destined not to go into healthcare. I wanted to be an attorney, and I thought I was going to be a litigator. And when I grew up, we were a fairly poor family. I remember my mom had to rent out rooms in our house to be able to put some food on the table. And I was concerned halfway through my education that I wasn't going to be able to either get into law school or afford it, and called my older brother, 17 years older than me, and said, "Hey, Michael, I'm having second thoughts about my career path." And as a great older brother, he convened a meeting with me, when we used to get together around the coffee table and talk, and said, "Hey, have you thought about healthcare? And it's a big industry, and there's a lot of ways to help people." And that really inspired me. And from there, I changed majors, I changed colleges, and launched my career in healthcare. I didn't at the time wanted to go into long-term care. I was really intrigued by the financing mechanisms of managed care and physician practices, and was fortunate enough to get a job right out of college in physician practice management as an analyst. And I had good fortune from there. Shortly after, I was able to build a small managed care company in upstate New York, where I was born, to serve individuals that had chronic illness that wanted to live at home and not in a nursing home. I then got into restructuring healthcare companies. After 9/11, I was fortunate to be selected for a role to turn around a struggling health insurance company that was also serving seniors. Tried my hand at a publicly traded managed care company and worked for Amerigroup Corporation, which today is Elevance, but was at the time the largest publicly traded Medicaid managed care company, and helped them get into long-term care. Spent 10 years at the Visiting Nurse Service of New York, which is the nation's oldest nonprofit home health care company in the United States. Their founder actually invented home care. And I led their insurance offerings for 10 years and grew them from nearly zero in revenue to $2.5 billion when I had left. and then tried bundled payments and worked for a private equity-backed company called Remedy Partners. And then 7.5 years ago, I was fortunate enough to have the opportunity to come in and lead a turnaround at Commonwealth Care Alliance, and which I always thought and knew about since the early 2000s, but I always thought they had the best way to approach their consumers, and were serving very, very challenging healthcare cases, primarily in inner city Boston, and just had this incredible reputation dating back to our founder, Dr. Bob Master, and was honored really to be a part of it when I was asked to come and lead our transformation. So I have been blessed in my career.
So really, it was your brother Michael that said, you don't want to major in political science, you don't want to major in English, maybe healthcare administration is the way to go. So we owe a lot to Michael.
I owe it all to Michael. And, Michael said, long-term care is where it's at. And I said, you're, not for me. And here I am, sort of working in an industry that has woven both the principles of healthcare insurance with long-term care services and supports. And I do owe a tremendous amount to him. Although I hope he doesn't watch this, because I would never tell him that. It'll make his ego too large.
Probably have to reimburse him, Yeah. Let's talk a little more about the incredible organization that you do lead and some of the issues you're working on. First, for those who may not be familiar with Commonwealth Care Alliance, can you give us just an overview of the organization and your unique approach to serving your members?
Yeah, so as you sort of introduced us, we are a Boston-based organization. We can consider ourselves an integrated care system. And we both operate, but also influence national models of healthcare for vulnerable populations. We advocate for policy, and we practice it with our consumers. And today, we serve over 100,000 people in 4 states. Massachusetts continues to be our primary state of operation and goes back to 76. But we also serve individuals in Michigan, which is our second largest market, and then California and Rhode Island. And we do that as an insurance company, but we also are a deliverer of healthcare services. We have several ways that we deliver care here in Massachusetts, both primary care as well as mental health services. We help people as they're nearing their end of life through palliative care and opportunities to die peacefully at home. We've developed programs that move sites of care to the right location. So we have a company called Instead, for example, that provides emergency department level healthcare in somebody's living room using paramedics, and it's remarkable. And as you said, we have what we call our uncommon care model, which has been identified as one of the best models of care in the country for complicated and vulnerable populations. It's fully integrated, meaning it pulls in all facets of life, not just healthcare, but things that address social determinants of health. It has the consumer in the center. Imagine that the consumer is actually the one that's dictating what their life looks like. It improves and focused on quality improvement, access, health outcomes, and really trying to make the best experience possible, all while reducing cost of care. And it's community focused. We emphasize behavioral and social factors that need to be addressed. And these, as you know, account for so many of the gaps in care that Americans experience. Every one of our members, all over 100,000, has a care plan that is individualized. So it's for them, not for the masses, but literally each individual. And it meets their own needs and helps them align the resources that can be available to them with the goals that they want to achieve. And just to give you an example, in 2022, over 60% of our members had received services from us or arranged by us that address a social need. And so it's not just medically focused. In fact, it's really more socially focused. And we leverage the healthcare delivery system. So we have contracts with tens of thousands of providers in each of our markets, and we help coordinate the care that already exists on a commercial basis to meet the needs of these consumers.
You know, I think I read when you came on board 7.5 years ago, you had 20,000 patients and you had a payroll of about 800 employees. And today you are in 4 states and you have 100,000 members and you have about 1,600 members.
We do, and that, you know, those are numbers that so it's when I came, we had about 15,000 insured members.
Right.
And today, you know, this year we will touch 120,000 people. And our workforce has grown. We've become an employer that is sought after by job seekers, even in the complex job market we have today. Our revenues are over 2.6 billion, which is essentially 4 times larger than when I came 7 years ago. But you know, again, what I'm most proud of is how many consumers we're able to impact in a variety of delivery and payment models that exist today. And so, you know, I have a brother that has a physical disability and suffers from some mental illness, and his name is Augie. And every time I think about a consumer that we're serving, I think of him. And now that we can do it for over 100,000 people, that really inspires me every day. And I think we can do it for so many more. And frankly, impact organizations that also serve this type of consumer and set the bar really high so that they can impact hundreds of thousands of people.
You have 120,000 members and you're in 4 states. What's the future look like?
Well, you know, we continue to evolve our operations so that we can serve as many states as possible and seamlessly serve all of these consumers. I am on a long journey here. This is a marathon for me. I don't see this as the next stop in my career. This is probably the last stop in my career if I'm so lucky to lead this organization. I see us in many more states, covering many more consumers and continuing to have the influence on local, state, and national policy for vulnerable Americans, whether that's a senior living with chronic illness and hopefully managing their situation in the community, an individual that's suffering from mental illness and desperately needing access to care and to try to get a game plan that will help them lead a really fruitful life, or someone that has physical disabilities and helping them, again, achieve all of their life goals and lead the same life that I'm able to lead as a fully ambulatory individual, and whatever that disability may mean. I think more and more people want to live at home as long as possible, and more folks now want to make sure that they're achieving the goals. I mean, I think the pandemic sort of shook us all up and said, wow, you know, life could look very different for a whole host of circumstances and some outside of our control. So I think we have a more discerning consumer that wants to be considered a consumer and not a patient or not something that's a cog in the healthcare wheel. And I think we have a tremendous opportunity to be in that conversation, either as the entity that's going to serve those customers or as an entity that's going to influence our competitors that will serve these customers. So I'm excited. And I think the future is really bright for our organization and for my opportunity to continue to impact change in this really complicated industry.
You know, there's so many companies in the medical industry field having problems attracting good talent, and you have 1,600 some employees. Are you having that problem?
Well, we have been very fortunate. Last year alone, we hired 800 people, right? So if you say, wow, 800 people and you have 1,600, or I think it's probably closer to 2,000 employees, that's like a whole new workforce. And we've had some turnover. And I think everyone has, because people have made different decisions around how they want to do their work, whether it's remote or people want to work less hours or just sort of reevaluated. We have been very fortunate to attract an applicant pool that wants to work for this organization. They are energized by our mission and the way that we do our work. They're energized by the fact that we are a growing organization. It's exciting to work here. Every day is different. They want to come and work with other gifted and talented people that are mission aligned, but also very intellectually motivated. We have been focused on diversity, equity, and inclusion in our workforce. We have been focused on being a best place to work in the very competitive Boston environment. So we have been fortunate, and I believe that as we look forward and potentially even, unfortunately, go into an economic downturn, people are going to look more and more at an organization like ours that has had 7 years of financial stability, 7 years of profitability. We've had growth. We've been innovative. We've been transparent and true to our workforce and our messaging. And I think it really aligns well with a future job seeker's values.
You've already touched on it, but maybe you can give one or two quick examples, but of the unique services that your organization provides, and why they're so important to the communities that you serve.
Yeah, I think, and there's a variety of them. And when you think about it, a health insurance organization, people traditionally think of, well, am I getting access to physicians and primary care doctors, or if we're serving individuals with mental illness and behavioral health challenges, are they able to see psychologists and psychiatrists and social workers? The answer is yes to all of that, first of all. But there are other things that we are able to serve consumers to address their social determinants of health, or in other words, things that get in the way of people accessing good health care and having a healthy life. So last year alone, we provided nearly 1 million one-way paid for rides to a doctor's office or to a social event. We had 7,000 consumers that needed their home modified in some way to make it more adaptable for them. A grab bar in the bathroom, an air conditioner. We went in and cleaned up trip and fall hazards, whether it's taking carpeting and taping it down, or rerouting extension cords, or doing pest eradication, or making sure there's a working refrigerator. We did that 7,000 times last year. 7,000 members, 7,000 people received 77,000 unique modifications to their home. We had delivered last year 560,000 meals to consumers. So people that needed to have food as part of their care plan, we all do, and they couldn't prepare the meal, they couldn't do what they needed to do. We provided that. And those are just a few examples of things we do when we think about a whole person, not just their medical diagnosis and what they need to live safely in their home or in the community.
Well, that's great. That really is an innovative way of approaching it. That transportation, that is extraordinary, because so many of them, that's a barrier. How do I get to the doctor? How do I get to the hospital? That is a major issue, and you've touched on that. So congratulations. I understand that Commonwealth Care Alliance has a big anniversary coming up, and is in the midst of a multi-year growth plan. Tell us a little more about your company's current footprints and how you hope to expand in the future.
Yeah, so this March we're going to celebrate 20 years since we were incorporated in Massachusetts, and that's really exciting. And that's incorporated as a health plan. Our roots go much further back as a primary care practice. We started as a free clinic for people with significant disabilities in the basement of Boston Medical Center. And as I've said, we have grown. Our revenues are nearly 2.6 billion this year. We're going to employ over 2,000 people, of which 55% are clinical. And we have many more markets that we are evaluating and identifying for expansion. For us, a market's a state. And whether that's through acquisition or partnership, joint venture, we are very, very excited. As I said, my goal is to serve as many individuals as possible, and to serve 2, 3, 4, 500,000 people with really complex chronic illness, physical disability, behavioral health challenges. That is in our sights, and our growth has been very deliberate and opportunistic. And we have looked at and chose markets that we believe can have a similar delivery system to what wonderful Massachusetts has, where there's good integration between state and federal healthcare dollars through a program that can coordinate that care. and we continue to again evaluate. And I hope at the end of this year we'll have another announcement to share with the marketplace. But in the meantime, I've got over 50,000 consumers right here in Massachusetts. It's been our home state, a state that's been great to us, and we continue to be focused on and do the great work that Massachusetts asks us to do, and continue to mature the relationships and the operations we have in Michigan, California, and Rhode Island.
One of the most urgent public health crises is substance abuse disorder. And here in Boston, we've seen an increase in homelessness related to substance abuse, particularly in the area known as Mass and Cass. And I understand that CCA has partnered with the state and in the city of Boston to provide some temporary housing on the campus of the old Shattuck Hospital. What other initiatives or partnerships is CCA pursuing to address the housing challenges?
Yeah, so first of all, our model that I've described, our unique uncommon care model, is designed to serve folks that have historically been disengaged or have had trouble accessing healthcare, but also challenges with housing and all of these other things that we're talking about. We did develop a particular expertise over time in dealing with and serving people with mental health and substance abuse disorders. And we all watched, and we've watched for years, the situation with Mass and Cass, and we were asked and honored to be a part of the initiative that is happening now on the Shattuck campus. And our program, which we operate there, and hats off to the Commonwealth of Massachusetts and the city of Boston for taking those bold steps, frankly, just to get those folks help. I know we've talked about, again, the stigma, and it was a cleanup, and we didn't want this on the streets, but this is people that have significant needs that need to be addressed and have been unmet. Housing has been the barrier, but housing is not the only challenge here. So on Shattuck, there is transitional housing so that folks can feel like they're in a stable environment, so they then can get the necessary mental health services that they may need, primary care services, and take steps towards addressing the challenges they may have with substance abuse and addiction. And at this point, we've had 80 people that have been through the program, and 55 of which are in permanent housing, which is remarkable because, again, that is the first step that someone needs on their pathway to hopefully recovery and to getting their unmet healthcare needs, medical needs, and psychosocial needs met. And this is one example. It's a marquee example because we've done it here in Massachusetts. It's been all over the news. And it's something that we believe we can take to other marketplaces. This problem, unfortunately, is not unique to Massachusetts. So we've continued to gain this expertise of getting folks engaged in the housing, and then understanding how they will participate in other efforts to improve their lives. And it's been a great opportunity for us to be able to do that.
Is there opportunity to expand that housing at Shattuck itself?
I think there is. We have provided some guidance to the Commonwealth of Massachusetts around what that scale should look like, whether it needs to be temporary cottages like we have at Shattuck, or if there's other pre-existing housing. I think the most important ingredient is not where they're housed, it's that they're housed. And that is a first step to helping an individual feel safe and be able to think about and start to address other things that when you're homeless, you're really only thinking about, am I gonna make it through the night? Am I gonna be able to be warm or safe and secure? And just understanding that basic human need is so critical to then taking the next step. That's the powerful learning there. And whether, again, it's instead of having 24 dwellings, if it's 50 or something else, I don't think that's the lesson learned. It's the housing itself. And I think we have a lot of opportunities. There are some housing spaces, but we've also learned through that initiative with the help of the dwellings that are provided by a company called Pallet, that there is a very defined cost of how much it is to stand up one of those and what that utility will be for somebody in need.
When you were putting that plan together, the temporary housing at Shattuck, did you have in your mind how long you think that individual homeless person would be housed there?
It's a good question, and I relied on. We have incredible expertise and depth in our organization of folks that serve individuals that have behavioral health and mental illness. We had an estimation that it could be 30 to 60 days. I think we're probably pretty close to that. And again, if you look at how people have moved through the program, what's really exciting, frankly, is that out of 80 folks that have gone through 55 are in permanent housing. And of those that are not yet in permanent housing, they may cycle back through. They may have left us and maybe regress, but we hope they'll come back. And we've provided a pathway for folks, and whether it's on the Shattuck campus or in one of the other operations, I think there's a much better understanding. But it's sort of hard to predict what the exact time is someone going to be there for a week. Part of it is really, if someone's engaged and willing, it's also about what's the available housing stock that exists for somebody to go into. That's a huge dependency.
Of course. Outside of my work at the New England Council, an issue that you may be aware of, I'm very passionate about, is supporting people with disabilities who I know constitute a very large percentage of your members. There's still a lot of barriers, and we talked about them earlier, that prevent or discourage people with disabilities from receiving routine medical care. What are some of those barriers that you see, and how is CCA working to help your members with disabilities overcome them?
Well, first, what we're talking about here is health equity. And as part of our efforts, we believe that healthcare organizations have to commit themselves to inclusion and competency in caring for people that have physical disability and mental illness. And again, as we talked a little bit about off camera, I had really the fortune of having an individual in my family that has a physical disability. As I grew up, and he's 15 years older than me, and we were sort of the only two in our household at the time, he was just my brother. He wasn't an individual that had anything going on with him. I see the world through that lens. And these are people that have just a different challenge. We all have some challenge in our lives, and this is sometimes there's a limitation physically that's there, that's my brother's challenge and others. And I feel that we have to be inclusive. My brother needs to be able to engage in society just like anybody else and not be labeled as someone different, but as really someone the same. And, for us, as we scale this out, we use a variety of tools, communication devices, interpreters, things that can reduce delays in diagnosis and treatment, for people that have challenges with vision, hearing, speech impairments, appropriate equipment to meet their situation. If it's a physical impairment, wheelchair, the right wheelchairs, first of all, that's critical, okay, or whatever that is. But to get folks the right treatment in another commercial setting. So if you need to have a scale that can accommodate somebody with a wheelchair, that should be standard practice, or a lift to help somebody out of an assistive device, any type of diagnostic equipment that can adjust. And all of this will reduce someone's, first of all, make them more comfortable. Again, these are consumers too, reduce their anxiety and build trust between the consumer that we desperately want to access good health care and the system itself. And if this is a bad experience, they're not going to get the care they need. And then, as we talked about, the transportation that we offer includes transportation for somebody that may be in a wheelchair. And you have to create a safe pathway for someone to access medical care. For us, sometimes it's in the home, so we bring the care to them. But oftentimes it's in a retail setting, the way healthcare was before the pandemic, really, and we're getting back to that. And that's a reason, from my perspective, that's a reason to get out of the house, to get dressed and have a purpose and an appointment for the day. And we want that absolutely to happen. And I think a big piece of inequity is the misinformation, misunderstanding. And one way to address it is to understand exactly where these exist. So one of the things we did several years ago that I stood up with some colleagues of mine is a nonprofit organization called the Center to Advance Consumer Partnership. CCA started this. This whole outfit is dedicated to transforming care for people with complex health and social needs. And it creates an authentic partnership between healthcare delivery and the consumer. And this is about us educating and helping other healthcare delivery systems figure this out. And it's not necessarily to our benefit. We've helped organizations where we don't have a commercial business offering. We've partnered with AARP and their Public Policy Institute. And again, this is really about, in America, creating scalable opportunities for policy and on-the-ground programmatic interventions that's going to improve equity across a very diverse set of older adults. The Black, Latino, Hispanic, AAPI, LGBTQ communities. This has to happen. And the fact that we have a role in this, a small role, but a role in this nonetheless, is really, really critical. And then, lastly, at the national level, we use our voice to support the needs of our members, which again, our members are representative of a much broader consumer set that exists in America that may not be our customers. And we feel that's a critical voice because now that we have over 100,000 consumers, we're able to do this at a scale in multiple geographies with multiple product offerings that will help inform those that set policy for the country. And we're really proud to have, a very small role in that.
Well, the worst of it is hopefully behind us, COVID-19 pandemic. This, of course, still one of the biggest healthcare challenges facing our region and our nation. I know your organization had some unique initiatives to support the communities you serve amid the pandemic. Can you just tell us a little more about those efforts?
Yeah, as I mentioned, I said my career took me to New York City early on. And that journey was right after 9/11. And I was part of an organization that was helping with the remediation and the cleanup of 9/11. And it was unfortunately an organization, we employed a lot of nurses, and at the time, most of which were female, and their spouses were firefighters, and many of them died in 9/11. And to sort of watch the anguish of that tragedy, as well as be part of the disaster remediation, and then, just over a decade later, be part of another organization that was cleaning up an area in Queens after Hurricane Sandy. And I was part of incident command for a 20,000 employee organization. When COVID happened, I said, I have some expertise to give here, and how can I help our Commonwealth? And there were a variety of things that we were called on to do. So first of which, if you recall, in the early days of COVID, the hospitals were completely clogged. And we weren't sure if one of the interventions of COVID was to put people on ventilators, and the emergency departments were clogged. And we had a lot of people in the healthcare system that had COVID, but they didn't need acute care, but they didn't know that either. So we essentially stood up 1,000 community beds in hotels to treat individuals that had COVID that were marginally housed. So meaning that probably a good place for them to go would have been an acute hospital care bed, but they didn't need a ventilator and they needed that level of care. We were able to run an operation that treated them in the community, in these hotels, and it created bed capacity in the hospitals. We did that operation for well over a year and a half. And it really created necessary capacity. The other thing that we did is we really advocated to remove a variety of prior authorization controls that were in place during COVID across the entire healthcare industry, so people could get necessary treatment. We made sure that our own members were vaccinated, and we fought to get the vaccine. Again, if you remember, it was hard to get vaccinations. We led, in conjunction with the then Medicaid director, Daniel Tsai, an effort to vaccinate any individual that couldn't get to a mass vaccination site. So these are homebound folks. and ended up working with across the entire Commonwealth with community agencies to actually be the ones that would administer the vaccination itself and document it. And we vaccinated over 5,000 people in small communities across the Commonwealth. And again, these were folks that they couldn't get to a mass vaccination site. It wasn't an option for them. So we coordinated that effort. And it's something that, we are incredibly proud of, all of this work. And we feel, again, as a human service organization rooted in Massachusetts, this is our obligation to raise our hand and say, we have something to contribute. How can we help you, Commonwealth, and direct our efforts towards individuals that may not be our own customers, but are certainly people in need.
Since the New England Council's focus is on federal policy and how it impacts a region's economy, we always like to wrap up these conversations talking about what is going on in Washington, D.C. So we're just a few weeks into the 118th Congress. As this new session of Congress gets underway, what are some of the Commonwealth Care Alliance top federal policy initiatives?
No, I appreciate the question. To wrap up, we have three. So first and foremost, integration of Medicare and Medicaid, or what we call duals. So we're really excited about right now the activity in Congress that's focused on integrated care for dually eligible individuals. And I think for the first time in many years, there's significant activity here. Massachusetts has been a long pioneer in developing these programs that better integrate care for folks that are covered by both Medicare and Medicaid. And we're founding company and partner of all these endeavors. And we hope that the bipartisan group of senators working on these issues will both look to our work in Massachusetts, but also really be ready to roll out models across the country for those that need it most. The second is Medicare Advantage oversight. So we're now at a time where nearly 50% of all Medicare beneficiaries are getting healthcare through a Medicare Advantage plan, like what CCA offers. We have Medicare Advantage plans for those, by the way, that are not low income in all four markets that I described. And we want to make sure that seniors and the government, who's really the steward of this, is getting the best possible product at the best possible price. And we've developed our own model to serve folks both with higher needs, but also individuals that have low income, but they're not eligible for Medicaid. And we want to make sure that they have access to really good health insurance. And we want to make sure that the plans like us are not in any way disadvantaging their consumers. So raising the bar for CCA will raise the bar for everyone. And we think that's really, really important. And then lastly, just the focus on behavioral health. So we're very pleased to see action in Congress last year to expand access and coordination of behavioral health care, which includes people needing treatment with substance abuse disorders. About 70% of our own OneCare members have a behavioral health condition, and efforts to improve and access high quality integrated behavioral health care is so critical to supporting the health and well-being of our members. And we support, obviously, further action to ensure approved access to mental health and substance abuse services across the country. I'd be remiss if I didn't mention the yeoman's work done by Secretary Sutters and other in the Baker administration for their focus and ongoing efforts to address the behavioral health crisis here in Massachusetts. And we're excited about the rollout of the behavioral health map and community behavioral health centers that went live January 1st this year. So we look forward to continuing our partnership with several of these organizations to ensure that Medicaid enrollees have access to these critical services that they desperately need.
Again, of course, thanks for taking the time to join us today. More importantly, thank you for the important work that you and everyone at CCA do to support the health of some of our most vulnerable members of our community. You've earned that, national reputation and recognition for its proven expertise in this complex care. Kudos to you and all your co-workers. I've learned a lot, and I hope everyone that tuned in today did as well. The only thing I would add, you mentioned your brother being sort of the guardian light in your life, and you think of him every day when you talk about individuals and what their needs are. I begin every day, and I carry every day a folder, and my folder today has my brother, and I'm reminded of him every day and how people with disabilities are treated. So your older brother, 15 years older than you, as my brother was 15 years older. So he was my teacher, and obviously he was your teacher as well. So I just want to, again, thank you for all that you do. And for everyone else who is listening, I hope you will tune in next month when our guest will be Dr. Kevin Taub, the CEO of Beth Israel Lahey Health. Hope everyone has a great day.